Cardiac arrest resuscitation has to be one of the most complex situations that we must confront in EMS. It can feel like you have 30 minutes to build a barbecue grill without any instructions. If you're not careful, you will finish with parts left over and a lot of doubts if you did it right. I'm here to help you. When your patient is in cardiac arrest, you are focused on providing the necessary care to achieve ROSC, not working through a checklist of questions to make the data nerds happy. Some of the information that I'm asking for here is simply not going to be known, or there's no clear answer. This is called the fog of war. Was it a witnessed arrest, or was the patient just having agonal respirations? Is the guy giving you information an off-duty firefighter, a bystander, or a family member? We don't have perfect vision in most any situation we respond to, but cardiac arrests can be especially chaotic. When we are under stress, our higher thinking skills are degraded. Please keep in mind that I'm just asking you to do your best. These are the questions that you will need to answer in each section of a narrative according to the Dod chart formula. Your dispatch questions are response priority, your dispatched complaint, a scene description such as a private residence, an apartment, a parking lot, any delays getting to the scene due to weather, distance, or traffic, and were you aware of EMD instructions being given per dispatch? Arrival questions. Delays locating or accessing the patient. Sometimes patients can fall in the bathroom and block the door from opening, which definitely delays care. What room or location is the patient found in? What position is the patient in? Who is doing CPR when you arrive? Sometimes the person who started CPR isn't the one on the chest when you arrive. What type of CPR is being performed? Compressions only or ventilations as well as compressions? Is there an AED on the patient? Are there any other obvious interventions, such as a Lucas device or an advanced airway? Anything notable in the environment, such as extremes of temperature, odors, lack of lighting, drug paraphernalia, evidence of trash or hoarding, anything that may affect the resuscitation? Who else is in the area, such as bystanders? History questions. Was it a witnessed arrest? When was the last known well time? What was the patient doing or complaining about before the arrest occurred? Had the patient been sick previously? When were they last in the hospital? Are there any advanced directives? Who started CPR? Was it compressions only? Assessment questions. How did you confirm the patient was in arrest? Did you feel for a pulse, or was it presumed cardiac arrest? Were there any telltale signs of death? Before you get too invested in resuscitation, did you check for signs of death like lividity or rigor? What heart rhythm was seen first? If basic airway ventilations are being performed, is there good compliance? If advanced airway ventilations are being performed, is there CO2 detection? Was the family consulted on their wishes? Maybe there's no DNR present, but we should strive to respect the family's wishes. If the patient is elderly, this might be an expected death. Consult with the family and make sure that a full resuscitation effort is desired. Did the patient fall and hit the floor? Perhaps a C-collar is indicated. Anything suspicious noted? Any injuries or anything unusual when you do your head-to-toe exam? Was the blood sugar checked? Per ACLS, a rhythm check should be performed every 2 minutes. If a rhythm check is done, your documentation should reflect that. Heart rhythms may be charted in either the vital signs section or in the flow chart. If an advanced airway is placed, make sure that you have end-tidal CO2 detection documented. Don't just blindly import the vitals from your monitor. Make sure that you are checking them for accuracy. Any outliers should be removed, especially if they don't reflect the actual patient condition. Treatment questions. Shocks delivered. Protocol now directs us to place the defib pads both on children and adults, anterior and posterior. Manual or mechanical compressions being performed. Lucas devices may be used in specific settings where the delivery of high-quality CPR manual compressions may be challenging or dangerous for the providers. This may include an inadequate number of providers resulting in fatigue, or CPR while in transport. Were advanced airways placed? IV or IO access? What medications were given on the scene? Make sure that you're recording the rhythm changes that correspond with the medications given. Reason for any deviations. For example, amiodarone is indicated in VFib, but giving it isn't as simple as throwing together a pre-filled epinephrine. Delivering a shock takes precedence over amiodarone. Because it takes some time to draw up, the rhythm may change before you have a chance to give it. This is important to document because it will otherwise appear that the drug was indicated, but you did not give it. Was ROSC achieved? If not, after 30 minutes of ALS care, the hospital is contacted, a time of death is received from the facility. Make sure you record the doctor's name and the facility that you called. Your flow chart should reflect all the care that was delivered, including rhythm changes. Also, any care that was delivered before you arrived should be indicated as well. Transport questions. Reason for transporting. Remember to base your decision to transport on protocol. There are reasons to transport and there are reasons to stay put. Sometimes protocols change and we don't always keep up. This will be as of April 23rd, 2025. There are 2 protocols that deal with cardiac arrest. Protocol 5-1, cardiac arrest general, and Protocol 7-6, dead on scene and termination of resuscitation. Traumatic arrest patients are often load and go cases, but there are exceptions as detailed in Protocol 7-6. Patients in medical cardiac arrest should not be transported unless you achieve ROSC, unless there's a scene safety concern, such as the family is getting aggressive or interfering with your efforts. Medical control will always supersede protocol. Medical control should be contacted in cases of persistent PEA or VFib. Remember, just because it's a witnessed arrest does not mean we should transport right away. Working the patient on the scene gives them the best chance at survival. 12 lead acquired. What is the interpretation? Who's in the back of the ambulance? Who's driving? Further assessment, further treatments performed? Hospital contacted? What medium? eBridge, phone, or hear radio? What was the rhythm at the destination at the turnover of care? And who was the physician who received the report? Sometimes the patient goes into arrest in our ambulance. If this happens, you might not have been following Protocol 3-7, the crashing patient/impending arrest protocol. I occasionally see a cardiac arrest occur because the medics on the scene recognize the patient is circling the drain and then try to hurry the patient to the hospital before they die, rather than aggressively treating the patient on the scene. If you haven't reviewed this protocol before, this is your wake-up call. Keep in mind that the doctor at the hospital is not going to criticize you for bringing them a patient. That lack of criticism should not be your indicator for whether you did the right thing or not. The doctors do not study protocols exhaustively and often judge EMS performance based upon the norms they've observed in their own system. Recently, Dr. Wall has encouraged us to get more comfortable with including one-to-one epi and magnesium sulfate in our treatment of respiratory distress patients. However, docs at other hospitals may act puzzled by this change because this is a new phenomenon and is still seen as outside the norm, despite it being in our respiratory distress protocol for over 6 years now. This is what it looks like when it's all put together. I'm not going to read this to you. If you want to read it, then pause the video now. CARES reporting is important on the back end. Medics don't have to deal with this, but there are many questions that must be reported to CARES in order to improve the outcomes in the future of cardiac arrest. The cardiac arrest reporting form that you have to complete at the end of the call includes vital information that's necessary to complete the CARES report. So please gather as much information on the scene as possible to include in this reporting form, because it all goes together in the end to make a big difference for future care.